No, you wouldn't give an they have fentanyl patches, they have catapress patches, they have scopolamine patches. Yeah.
It's local anesthetic.
I was on it for 10 days, and that was tremendous. It was a big help. But, you know, I like to try to not use medication at all possible. And my doctor and I talked about this, and instead of going on all these, you know, extra prescriptions and whatnot, try to use Tylenol. And they said, I think it was, I used 2 tablets, you know, every 4 hours. And there's some days when I do that, but now hearing you, it sounds scary.
Well, what we always like to say at NPS meetings is talk to your doctor and put it to your doctor. Say, I am concerned, I heard from this crackpot LA kidney doctor that it wasn't good for you, and I want to know, are you happy? Do you think it's safe? And one of your jobs will be to, well, and your job is to convince me that it's safe and to consider all of the reasonable alternatives to solving your problem.
Now, how do you feel about, like,
Acupuncture. For pain
In my institution, we have an acupuncturist who is a psychologist who works in our pain clinic, and he has, boy, does he have an acupuncture clinic. And I kind of don't think he'd be doing it if there wasn't some benefit. So,
you would recommend even that route?
you know, try everything. And I'd say one advantage of acupuncture, I don't believe there are any drugs involved with it, right?
On the practitioner's part?
Yeah, no.
Yeah, the mention that sends the trans-electrical neurostimulator, it sends a pulse of electricity. Too often to get a response high enough that you get a muscle contraction.
I have a member.
Yeah, it's been helpful.
I travel, yeah.
And also you can, some acupuncturists will do it with electricity.
Yeah, they have much more
Then you
power.
kind of like sense that's being delivered.
Yeah, mine is a lot more mild dose, of course, but it
Yours
works
sends,
wonders.
it's a little pad, so that
Yeah,
you
little
place on
pads.
your skin, and then it sends the electricity over it.
It works really well. Yeah.
All right, I'm going to move on to the next question. How frequently are literature reviews published on NPS? When was the last one, and when will be the next one? No pressure.
There's one last year that I wrote. We probably have to redo the gene reviews next year. I mean, there's been...
I think we've been very fortunate since we all started getting together on a regular basis,
Yeah.
that they've been coming out much more frequently than
I
they
think
have in the past. I
There's
know
been
that.
at least 5 in the last 10 years.
Yes, very comprehensive.
Find those specific things. I mean, I've been going on Medline and those kinds of search engines to try to find stuff, and this was before knowing any of your names, so I
I was about to say, if you probably Googled Ian McIntosh or Elizabeth Sweeney, you would get a pretty darn good article, wouldn't you agree?
Yeah, but
Modesty would prevent me from saying so. If you email me, I'll send you the PDFs.
Yeah, we can get one to you.
But for those of you who venture onto PubMed or Medline, the key thing is setting up the search terms, and actually it's evolved pretty amazingly well in the last 15, 20 years, where you can set up these searches, but if you have the key terms and they're comprehensive, you can pretty well catch whatever is out there, and I'm sure.
Like Nail Patella and review will bring down an awful
And
lot.
if you put Macintosh on there, you're probably all set.
What you would Google is PubMed, P.S. and Paul, U.B. and Med, like,
The problem with PubMed is that if you're not within an academic institution that has subscriptions, some things are open access, and you'd probably be surprised how many you can just pull down the PDF of the article because they've been released. But you'll find a lot of journals that if you don't subscribe, they're not openly available, and you may have to ask a friend.
Nudge someone, yes.
Nudge someone.
Please help. Please help.
Oh, we have a question.
or
Yes.
email the author, the
Yes.
email address.
Yeah.
You can email the author and request a copy as well.
Which they're actually in many cases not really allowed to give, as I found out, but sometimes they don't notice that a PDF, that the copyright belongs to the journal. Yeah.
Nadia.
I have a question for Susan. I wanted to know, my daughter is right now in middle school and kind of late, so she's fine. I wanted to
Those are questions probably every parent has. This is when I'm talking to parents that, obviously I don't get a lot of chance to talk about other parents with Nail Patella Syndrome, but when I'm talking to parents of people who have kids with diabetes and their kids are heading off to middle school and they're worried about high school, I tell them, this is hard enough. So take on today, because you don't know what kind of teenager she's going to be. It may not even be a worry for you at that time. You may have the answer right there. So I would say do what you think is best for her right now, and when that time comes, make that decision. It's hard enough to do now. And sort of related to that, I think that's that day at a time kind of attitude again. But it's so hard because as a parent, you're worried about every step along the way. But challenges come up that you never anticipated, or things resolve that you never thought would. And especially for those of us in the room who have Nail Patella Syndrome, you can say what was an issue for you in middle school became irrelevant in high school, and you had a whole nother set, And so it's, yeah.
Yes.
This question is for Dr. Lemley. When we are talking kidney effects, typically both kidneys are affected exactly the same way?
If they're affected with nail patella?
Yes.
Yes. If they're affected, remember we have the two types of effects. One that probably everybody has, which is the faster than usual decrease in overall kidney filtration function. And then the other is if it's combined with a podocyte gene regulated by LMX1B, it can be more severe. Both of those is every single unit in both kidneys.
And then when there is a transplant, when one is left the way it is and just,
Well, we don't in general take out the kidneys before transplant unless they're causing problems. So some people have malignant uncontrollable hypertension and they're on 4 meds and the kidneys are failing, so they're not getting any blood cleaning from them. We tend to take those kidneys out. There are a few other times when we take the kidney out. In general, the kidneys are way back here. So some people think we transplant into the same place the native kidneys come from. That wouldn't work real well. We transplant in a larger person down in the pelvis. So it's very easy to examine the kidney. But in general, your old kidneys have died and they just sit there and kind of corrode, go away and scar, and a new kidney's put in that's just completely separate.
Can I ask a follow-up on that? If you started to spill protein, that started the last few years, is it for sure that they're going to continue to worsen, or can you halt that at that stage or reverse it?
Well, those are very good questions, and I don't have the answer despite working on this for the last 13 years now. Most kidney diseases involved with progression are associated with high-grade proteinuria, which may or may not go up. So the first thing to know is, what does it mean to spill protein? Does it mean you went into the doctor, they did a dipstick in your urine and said you had protein, which ain't adequate, or did someone give you a ratio? And do you know what it was? Okay, so if that's going up, that's generally not a good sign. If that's a high number, say over 2, that's probably not a good sign. So if it's a low number, that could be consistent with just staying that way forever. So if you have high-grade proteinuria and it's going up, you want to make sure someone's measuring your kidney function.
All right. Yes, Mary.
The only thing I think, other than a kidney stone, which I can tell you hurts like stink, that causes pain in the kidney region other than a literal infection of the kidney, is things that cause the kidney to swell. So some forms of nephrotic syndrome are like that, not NPS that I know. And I don't know why God gave the kidney a capsule surrounding it that was sensitive to pain, because I'm not sure why we need to know that our kidney's swollen, but it is exceptionally painful. That's what stones hurt from. If they're obstructing, the kidney blows up and it stretches acutely, as Sam was saying. If it's very long-term and slow, you won't be aware of it. If it's acute, it doesn't feel good. Right, well, stones the pain tends to migrate down to the groin classically in a stone, but I hear about people complaining about kidney pain, and it tends to make me think they have moderately acute swelling of their kidneys from anything that would cause that.
Yes, Shannon.
No. I'm elderly and having a hard time hearing.
The microalbumin and also the serum creatinine. When I took him to the doctor, I pretty much begged him to do the microalbumin because I guess it was important, but he refused to do that and rather did the serum creatinine. And that was it. Should I demand it?
Well, they tell you different things, and the creatinine tells you basically, here's what your kidney function is. The problem is it's a really crude indicator of that. So you can take someone my size, and I could have a normal creatinine of 0.9, or 1, or 1.1, or 1.2, and any of those, if a nephrologist looked at me and saw that, they wouldn't say, oh my God, something's wrong. Well, let's say it was actually 0.9. God meant it to be 0.9, and it went to 1.2. That's a 1/3 loss of kidney function, and I stayed within the normal range. So creatinine, if it's twice what it should be, there's a problem. But it's not very good for early or small changes. The microalbumin is unbelievably predictive, actually within the normal range, which is under 30 in different units than for the other quantitative protein in the urine ones. If you break it up to 0 to 10, 10 to 20, and 20 to 30, each of those within the normal range is predictive of cardiovascular mortality. The higher you are within the normal range. So it is incredibly sensitive, and that's way below what a dipstick would ever pick up. So it's very sensitive for anything that's abnormal. It's so sensitive you have to be careful that if your kid is going to get a check on a first morning specimen, hopefully, he doesn't have a cold or allergy, because it'll make it abnormal.
Did you say 24 hours?
No, I only do first morning specimens. In pediatrics, that's fairly common because a lot of our kids are not, how should we say, continent at night. Yeah.
So that is definitely something that
It's very, very sensitive. And if it's normal, it gets abnormal from colds and coughs and whatever. There's no artifact that makes it normal. If it's normal, it's normal.
I'm going to carry on because I'm watching my watch, all right? So forgive me. Please discuss collagen abnormalities. How does this affect NPS? Are there diet or pharmaceutical resolutions?
Yeah. Okay. So the only way that I know that an LMX1B mutation directly affects collagen is in the expression of a type of collagen that constitutes the glomerular basement membrane in the kidney. Anything else is so far downstream in terms of formation of limbs and so forth, that structures not being in the right place. It's not a direct effect of collagen. And if the question is anything to do with chondroitin diets and stuff like that, then other than their the small benefit they can have in alleviating osteoarthritis, then that would be the only thing there. So if you're talking about shark cartilage and stuff like that, then yes, that will somewhat alleviate arthritis, but nothing else.
Okay. Next question, probably for Steve. What can be done for severe spinal stenosis?
For severe spinal stenosis, you want to treat everything conservatively as long as you can. If you have severe spinal stenosis, you're getting radicular complaints or radicular findings where you're having radiation of pain, numbness or tingling or weakness involving a specific dermatomal distribution in the area where you have the spinal stenosis. This could be treated with possible steroid injections, epidural injections, which would be the next invasive procedure to do. If that doesn't work, after a series of 1 or 2 or 3 injections, the next thing would be surgical intervention, which would be decompression and possible spinal fusion.
And then one last question, and I think I know the answer to this, but I'll let you answer it. Best and most durable solution to knee pain?
Not to have it. I mean, that's a very broad question. What's your answer to that?
I'm assuming you're gonna say exercise, keep active.
Of course. Well,
Low impact.
low impact.
Sorry, yes, Jane.
It depends. We hit this a little bit more in the nephrotic syndrome diseases outside of NPS. The kind of the good news, bad news part is there are lots of side effects with being nephrotic, lots and lots of side effects, and it's hard to treat. As the kidney fails and stops filtering through those little filters, it stops destroying protein. So what we teach people is it goes out in the urine, and that seems very logical, but that's been known for 60 years not to be true. It's basically destroyed in the kidney, but if you don't filter, guess what? Can't destroy protein, you can't get rid of wastes, but you can't lose anything good. You can't lose vitamin D through vitamin D binding protein going down. So what tends to happen as you go into kidney failure with bad nephrosis is a lot of the most irritating things like swelling and other things tend to go away on the nephrotic basis. So that it first goes away with transplant. If you're transplanted when your kidneys are stone, so a lot of people were on dialysis for a while and have no urine output and no apparent kidney function, then if the kidneys aren't causing hypertension or anything, it has no influence on anything. Some people will still have enough kidney function, they can lose protein, and that's another case where we'll do nephrectomies, we'll cut out the kidneys. If we have one of these diseases that can come back in the transplant, and we're going to check it by the protein in the urine, and of course we've got the old kidneys feeding into the same bladder as the new transplant kidney, that there are times when we actually do a nephrectomy because it will make it harder to diagnose a recurrence. If you have enough function, you're still dumping protein in. And sometimes that will happen. You don't have enough to keep you off dialysis, but you've got enough to lose a lot of protein in the urine. It's very individual, though.
Vitamin D or a lot of this, are you recommend doing low density or anything else?
Well, it depends in whom. The problem with bone density in kids, and the younger the kid, the worse the problem is it's not well standardized. So in the past, it was completely unstandardized, and we'd try to send someone who was 10, and their insurance would insist that they went to Grandma Moses's DEXA center, and you would get standardized things for women in their 60s and 70s. And so strangely, all of our kids were completely abnormal. And then they started going down to 5 by the Luna, and there's 2 main makers of DEXA machines in kids. It's still never going to have, the bone structure has a high effect on how you measure bone density. And bone structure is different in kids than it is in adults. So there's a friend of mine at Children's of Philadelphia who's like the big, renal bone specialist in nephrotic syndrome, the other things. She thinks you don't believe any of it. And I think it's just, it'd be wonderful if you could measure that. But, you're probably just as good getting an X-ray and having Steve look at it, or me look at it, and looking at the cortex and looking at the trabecular structure and say, I don't see any osteoporosis there or osteopenia.
I think it was a Baylor study created a set of normal values for bone density in kids. We were using that in our study at Hopkins.
They're better than they used to be. The problem is they're somewhat dynamic even within kids. We're doing a study now at Children's with UCLA and Loma Linda where we're doing CT. And so we're actually getting, because that's by far the most quantitative thing you can do of like spine and femur, to try to find a new way to really be quantitative. But it's just very different in kids. They're less, it's always going to be a smaller database. They're dynamic and growing. Their bone structure is different. So it's harder. What I would do for sure is probably everybody who has any medical problem should have their 25 hydroxyvitamin D level checked. Because if you just go on the streets of LA and grab 100 kids, hold them down, poke them, and get some blood, 25% will be deficient in vitamin D. Because you can have too much, but it's hard. You're not going to get it from being out in the sun. You will get skin cancer from being out in the sun. But vitamin D, people are very sensitive about giving it because there are cases of toxicity from it, can cause problems. It takes a lot of vitamin D. Right, because the kidney will break it
Okay,
down rather than
One last question from
activate it.
Angela, and then we can wrap this up for today's story. I'm sorry.
Just to follow up, I know there's no direct way that I know of measuring the bone in kids. We're talking about the DEXA scans, but if you wanted to directly look at the bone, this is an invasive way of doing it. I don't think anybody's doing it. It just came to me while we're talking about doing a bone biopsy and looking directly at the bone, osteoclast, osteoblast.
We do that, actually, but we do it in the sense that UCLA does it. It's really to be able to do a bone biopsy. So all of the fellows there in pediatric nephrology learn how to do bone biopsies because Isidro Saluski is the world's authority on it in renal failure. And so they basically give tetracycline, which stains bone and gives you a mark, a fluorescent mark, for like 3 days, wait, I can't remember how many days, give you another dose for 3 days, and then they go in with a drill and take a piece of bone and they see how much the bone is grown, and you can tell whether bone is what they call adynamic, that there's no turnover or it's hyperdynamic. So the gold standard is, in fact, bone biopsy, but you have to know. Well, it actually doesn't hurt. It's an outpatient procedure. The problem is you have to have someone capable of doing the biopsy and a pathologist capable of interpreting the biopsy, and that makes it's just not done anyplace.
All right. Is this a really quick one?
I think so.
Okay.
The condition of malformation Chiari, Chiari malformation, has that been associated with NPS study? Has there ever been a study done to see if there is a possible link?
I remember a couple of NPS patients being told that they had Chiari malformations. One of them was a type 1, which some authorities believe is a normal variant. And so I'm not aware of anything over and above that. So we'd have to do MRIs on 30 people.
So there hasn't been any study?
Yeah.
All right, we're going to wrap up this session now, but before everybody runs out the door, because it's 7 minutes to 4, so I just want to give everybody time to get out. One thing I'd like for us all to do is meet over in the lobby over there, and we're going to find a nice place to take a picture of all of us. I had thought we would do that up here, but this ran a little bit too close to 4 for my comfort. Second thing, or now there's 3 things. There's a physician in Arizona, Nancy? Where is Dr. Beal? Utah. There's a physician in Utah, I believe he's a radiologist or an orthopedist, and he's very interested in getting x-rays of people's ankles. If you've had surgery, have not had surgery, he's doing some research on subtalar joints in ankles. So if you happen to have x-rays of your ankles, let me know. I have his email address, his mailing address, all that good stuff that we can send them to him. Third item, tomorrow morning we're starting at 9 a.m., which means you get to sleep in a little bit. Yay! And we'll be back in this room again. If you are interested in signing up to be part of the group sessions that we're going to have with Susan, please let me know. I'll have sign-up sheets outside after we go out of here. And there was one other thing. If you have not had a chance today to speak with Dr. Mansour or Dr. Zaretsky, orthopod or eye doctor, please meet me outside because they will meet with you in the lobby out there afterwards to do that before they go home either later this evening or tomorrow morning. Thank you.
Huh?